is the Director of Infant, the Irish Centre for Maternal and Child Health Research, and Professor of Neonatal Physiology at University College Cork. Geraldine, I'm sure many of you know her name, is a leading expert in the field of neonatal neurophysiology. And with her research group, she's got an international reputation in seizure detection and brain injury. In fact, one of her seminal papers on our incompetence as caregivers in diagnosing seizures still remains a keystone in my teaching today. She and her team have since been developing automated algorithms for monitoring brain activity and developing remote monitoring tools. She's about to tell us all about this in her presentation on resolving the conundrum of seizure detection in the newborn. Thank you, Geraldine.
Thank you very much, Julie, and thanks for the invite. I'm delighted to be here. And I suppose I should start by saying that I'm a neurophysiologist, as Julie said, but I've spent a lot of my time working in neonatal units, both in London and here in Cork. And I've learned a lot from my neonatology colleagues, and particularly about neonatal seizures. And the title of my talk is Resolving the Conundrum. I wouldn't say we've totally resolved it yet. I don't know everything about neonatal seizures, but I'll tell you what I do know and how far we've got along the journey. So I'll just move things around here so I can get this talk right. So just a few disclosures, and I am going to talk about the ANSWER study, and which is a study of automated seizure detection. So I just put that disclosure in as well. And thank you for not taking pictures. I actually don't mind taking pictures of the text slides and everything else. It's just I am going to show you some videos and pictures of babies. So obviously I have permission to show them, but I don't have permission for them to be used by other parties. So if you don't mind, it would be a huge help if you don't take pictures of any videos, even though I have tried to blur the faces and things like that. It's just, it's best practice not to. So thank you for that. So what I'm going to talk about is what we know about neonatal seizures so far, the incidence, the etiology, and the outcomes. And I suppose I always think about when we're starting off looking at neonatal seizures, it's almost like, it's like being a detective, really. You're trying to detect a problem that sometimes can be really hard to figure out, but you've got an awful lot of tools already. You know, as a neonatologist or a neurophysiologist or a neurologist, you know a lot about the baby when they come into the neonatal unit. And it's how you use those to inform your decision about some kind of movement you might be seeing in the baby. Timing of seizures is important, and it tells us a lot about the etiology as well, and I'll discuss that. And then, of course, we'll have to talk about when you're detecting seizures, what tools can you use? And I think one of the tools that we sometimes gets forgotten about a lot is the actual clinical presentation. Let's look at the baby. What's the baby actually doing? Because you can get a lot of information from the type of movements they're doing, whether they're clonic seizures or tonic seizures, or they may be just doing some automatisms. And that's a good start. Video is really important. If the seizure, maybe somebody has done a video clip of it, and that can be very useful just on its own. But of course, I will talk about EEG because it is our gold standard for diagnosing seizures. And we'll talk about AEG and EEG and, you know, the pros and cons of each. And finally, I'll just end with a bit about where we are now and how automation is helping us to detect seizures. And of course, what we're always trying to detect. And what I will talk about in this talk is I will use on all my slides, if I'm showing EEG, I use both AEG and EEG. And I have to say, in, you know, what I advocate for in all, you know, I do continuous EEG monitoring, but we always use AEG as well, because there are huge advantages in the AEG because the signal is more compressed and you can see longer term trends. So we use both all the time. And actually, I think I probably struggle looking at an EEG now without the amplitude integrated EEG as well. So things have evolved, I think, and I think they're both complementary to each other. So now quickly, I always think it's a good idea to find out who your audience are and what your current practice is and what you use. So I have no idea how this poll is going to work, but the experts that are helping with this will make all this happen by magic. So there's a few questions on the screen here that I just want to know from you. When it comes to neonatal seizure detection in your own unit, what do you use primarily to support your decision of whether or not something's a seizure. Do you just have no EEG and you're using clinical recognition alone? Have you got amplitude integrated EEG only? Have you got a conventional EEG only? Or do you have AEG and sometimes you can get some continuous EEG as well if you need it? So I'd be interested to see what your what this audience has actually. So I'll have to hand this over to somebody, and hopefully a poll will, the results of this poll will appear. And of course, you've also got the other question that came up as well at the end about, you know, do you have 24/7 monitoring, which is great, actually. I'm just saying about 82% of you so far do have 24-hour availability of some kind of amplitude integrated or EEG monitoring. And then, as you can see, the results of the how you recognize seizures, a little bit of variability. Very few, 13% of you using clinical recognition only. 36% have AEG only. 9% have access to conventional EEG only, and 42% have both, which is good actually. Okay, great. It's interesting to see. So I think, look, I think from what I'm going to talk about, I'm going to talk about everything, all of the above, really. Clinical recognition of seizures and AEG and EEG. Thank you for that. This is a nice study, actually, that's come from the UK, and it's just a recent study from Sarah Meskel and colleagues, many of whom I've worked with and know well. But it's nice to see, you know, what is the availability of cerebral function monitoring in the UK. This is a very recent study, and you know, it's very high actually in many areas and many networks actually, which is really good. It's a little bit, you know, there's a bit dispersed in some areas, but I mean, I think generally there's the availability of CFM, amplitude integrated EEG is actually quite high in the UK. I haven't seen any other studies done in very many other countries like this, so this is actually quite nice if you haven't come across it before. So, almost 20 years ago, Malcolm Levine published this paper on the clinical conundrum of neonatal seizures. And at the time, I was really interested by it, and I had lots of chats with Malcolm about this. And I think we've come on a little bit more, and his main concerns were at the time that there was poor concordance between the electrographic and clinical seizures. Yes, there are, and we know a lot more about that now. And there was a lot of concern about what is the impact on neurodevelopment, and I'll show you some results about that now. We know a lot more as well about how seizures themselves are impacting neurodevelopment. And there was poor evidence on the efficacy of commonly used drugs, and that's improving. Still not fantastic, but we've a lot more studies have come on board. But and he was worried about the overtreatment was common. Now, in this talk, I'm not talking about seizure treatment. It's really about how we detect seizures, because in my mind, there's no point in figuring out how you're going to treat them if you don't know how to detect them accurately. Because from lots of studies, we've seen that many seizures have been, sometimes there's overtreatment and there's quite often undertreatment. But unless you know the seizures are happening and when, you can't treat them in the first place. So in my mind, accurate detection is essential before you embark on any treatment plan for any baby in your unit. But what we know about seizures so far in terms of the incidence, we know they're very common in the neonatal period. And they kind of get a bit more common again as we get older, because we're all living a bit longer. Before, we used to say they were most common in the neonatal period, but now we're all living longer. We're seeing an emergence a bit later as well in life. But certainly in the neonatal period is when we're going to see an awful lot of neonatal seizures, more than any other time. But we do know from many studies that the commonest etiology of neonatal seizures is by far hypoxic ischemic encephalopathy. And in this talk, I am going to focus on acute symptomatic seizures, although I know there's people prefer to use the terminology now of acute provoked seizures. I'll probably revert to symptomatic because that's what I'm so used to. But really, these are seizures as a result of a particular brain insult or a brain injury that's happened. And as you can see on this slide here, the commonest cause being HIE, and this is in term infants, but in the preterm population, it's quite often an intraventricular hemorrhage. Infection and congenital genetic factors also cause seizures, but not to the same extent as, for example, hypoxic ischemic encephalopathy in our term newborns. But we have emerging evidence now. And I know in Malcolm Levine's study, he was worried about do we really have strong evidence in humans? Because there was a lot of evidence in animal work, but can we see in the human population that we have, seizures impact neurodevelopmental outcome on their own? And I think it's important to say that, and this is one study we did, looking at seizure burden and outcome in neonates with HIE. And we were actually able to see that seizure burden itself, when we controlled for things like the grade of encephalopathy and cooling, non-cooling, the seizures themselves actually caused a higher rate. If the high seizure burden was associated with poor neurodevelopmental outcomes. And we actually found a cutoff of about 40 minutes. If an infant was having more than 40 minutes of seizures, the seizure burden was 40 minutes, we found that was more likely to be associated with an abnormal outcome. And this is a nice study as well from Divian Shah and colleagues, and Julie's in there as well, actually. But I often use this because it's a nice study looking at electrographic seizures and MRI injury. And this was a study using AEG as well, and really two-channel EEG, and really showed that there's a clear association between high seizure burden and MRI injury. So the evidence has mounted over, since Malcolm wrote that first paper, it's very clear that we can say the seizures themselves are associated with MRI injury and poor neurodevelopmental outcome. So it's important that we recognize seizures and we treat them. And I suppose we have to really look back at, we're looking at a very immature brain. When seizures are happening in the newborn period, as you can see here, they, our babies from 23, 24 weeks right up until birth, they're susceptible to seizures up to this, in the whole neonatal period. But at a time when there's so much development, so much happening in the brain in terms of all of these different, synapses, like the connections are being made, gliogenesis. So seizures, if they happen, will impact on how connections are made in the brain. And these will be life-lasting, as we can see from now when we look at later neurodevelopment. So it's really important we recognize them and we try and stop them as soon as possible, because they are, let's face it, they are an emergency. They're a medical emergency in our neonatal unit. It's a neurological emergency. So what's the other factor that we have to consider about neonatal seizures in the immature brain is that we won't maybe always see them, because we'll see them if they're in the primary motor cortex. So we have to remember that if a baby has a seizure and it's in the motor cortex, we might see a hand movement, a leg movement, some motor sign. But if they're having a seizure outside of that area, say for example in the occipital region or maybe in the temporal region, they can't tell us, they feel strange, they're nonverbal. So how do we know the seizure is happening? We have no clinical clues. And so this is the part of the conundrum that we have with neonatal seizures, is that we have an immature brain. We have a baby who can't tell us that if it was an adult or an older child, they would say they're feeling a bit strange. If it was a temporal lobe seizure, you might have visual symptoms. If it was an occipital seizure, but of course, babies can't tell us how there's some visual sign associated or something else. So we really have to use other tools. But not surprising then that, seizures, a lot of, still I often get asked, should we be treating electrographic seizures? And to me, what's the difference? If it's an electrographic seizure, it needs to be treated. If just because we can't see a clinical sign associated doesn't mean it isn't as important. So I hope I can convince you of that. But clinical seizures, Julie referred to this study earlier, I think, but they're hard to recognize. And I don't think we should beat ourselves up by saying that, we can't always see them, because most people can't see all of them, because it depends on where they are. And a number of years ago, we did a study. We asked a number of healthcare professionals to look at videos of 20 newborns that had either seizures or they had some movement that looked a bit repetitive. And we asked them to say, but we knew that 11 of those babies had seizures and none had non-seizure events. And that was 137 healthcare professionals in 8 neonatal units in Ireland, the UK, and the US. And they identified 50% of the events in those videos correctly. And definitely, any babies that had tonic seizures, they were most likely to be recognized correctly. A seizure like this, which you can see on the video here. But unfortunately, the inter-observer agreement was very, very low, because what we actually found in the events that were correctly identified, the raters didn't agree with each other. So, of course, as you know, for an inter-rater agreement, you want it to be as close to one as possible. And unfortunately, we didn't see that. So, clinical seizures, events when they happen, they can be very hard to recognize. But if they're clonic, they're most likely to be a seizure, and they were the ones that are most accurately recognized. But what was interesting for us, it really didn't matter what health profession you were, and how many years you were in the profession. It really didn't help you in terms of recognizing those neonatal seizures. And of course, as we all know, and as you can see from this picture here, in this particular baby, the seizures, even if they are clonic, can be quite subtle sometimes, and you can't always see it very clearly. And in neonatal units, I know you know very well, they're very busy units. Somebody can't just be there and stare at the babies the whole time. So it's really important that we have some other tools to help us to distinguish even sometimes those motor seizures. And when it comes to the clinical signs of seizures, we do know that really, we all use this tip of the iceberg analogy, but I think it still holds. Quite often, the clinical seizures that we see are often the tip of the iceberg of the true neonatal seizure burden. And Bob Clancy said this many years ago, and it still holds true today, that if you're seeing seizures in a neonate, quite often it may not be, the seizures may have started earlier than when you saw the first clinical sign. Sometimes neonates don't have any clinical signs at all. So I think, we have to look at, well, are they in a high risk group? And we need to monitor them with EEG to be absolutely sure that they're having seizures. But in a study we did a number of years ago, when we did a video EEG study, and we looked at when we reviewed the videos afterwards, and we looked at how many seizures were detected in a group of babies that had EEG monitoring, they were term infants, we found that only 9% of the true seizures were the seizure burden was actually documented in the medical notes. And when we look back at the videos later and look very carefully, with the benefit of hindsight, no pressure, we were looking very carefully at the video, we saw that there was 34% of them were evident on the video review. So we really have an issue with neonatal seizures, is that, even if we work really hard to try and see them all, sometimes, they just, we can't estimate the true seizure burden. And of course, the other issue we have is that when we treat seizures with the most commonly used anticonvulsants or anti-epileptic drugs, or phenobarbital, phenytoin, we get this uncoupling whereby if there had been a clinical sign and there was maybe a clonic or a tonic seizure that was visible, when we treat those seizures, we find that they abate, the clinical signs go away, but the EEG seizures continue. So you get this, I put this picture up always of the calm waters, because it seems as though you've treated the baby, the seizures have stopped if there had been a clinical signature. But in actual fact, quite often what's happened is that, yes, the clinical signs have stopped, but the EEG seizures continue, which is why you need to be very vigilant. But I suppose the thing that always, you have a lot of, when you've got a baby in your unit, there's a lot you know about that baby when they come into the unit. You know a lot about the birth history, maybe the antenatal history as well. You've got a lot of their, their APGAR scores, their lactates and pHs. You know a lot about their risk, really, for neonatal seizures. And I think this can help. And there are certain, and we did look at this a number of years ago to see where high risk markers, could we predict seizures with things like just the pH and APGAR and lactate? And really, if you look at this slide here, you can see that, the predictive values were very, very poor. And we combined them. If we looked at pH, APGAR, and the need for intubation, didn't really help us very much. So unfortunately, those, pH and your blood gas results, really, need for intubation on their own, aren't really going to help you to predict which babies are more likely to seize. But we do know now from lots of studies that there's a number of studies that are emerging now to show that really the best thing for predicting which babies will seize are the background EEG pattern. And I think, with our amplitude integrated EEG, or if it's continuous EEG, both are equally good, because you don't need multi-channel EEG to actually estimate what the background pattern is like. So, if you have 2 channels on your EEG and that background pattern is very poor, with, say, just a very suppressed EEG or very, very low amplitude, that's going to put that baby at high risk of seizures. And we know that. For example, like in this picture here, I mean, you can see at this particular time point, this is the AEG and this is the EEG, which is very suppressed. I mean, if you've got that pattern on a baby that maybe had some perinatal depression, you're monitoring because you think the baby has got an encephalopathy, and you see this pattern, they're at high risk of seizures and they need monitoring. They need careful monitoring from as soon as possible. And this particular pattern here on this EEG, this is the EEG within hours of birth at 3 hours. And then we looked at the EEG then a little bit later at 12 hours, and seizures start to emerge. The EEG starts to recover, and we often see this. EEGs recover, and then the seizures emerge because you're in that secondary energy failure phase, particularly when it's a baby with HIE. The thing I would say, though, is that, and there are a number of other studies as well that have shown that it's the background pattern that's really predictive of the babies that will seize. But a word of caution, because I think if you have, and we like to see a normal EEG very early on in a baby, if it's normal or mild, that usually makes you think that these babies won't seize. However, if it's a baby with a stroke, that rule does not apply, because you can have quite a normal looking EEG in a baby with a stroke. And if you look at the AEG here, you can see nice sleep cycles, continuous EEG pattern in the background of this EEG. And during a phase of active sleep, in actual fact, this baby's actually having a seizure, as you can see here over the left side from the MRI. So it really depends on the etiology and what you consider is, if it's a baby with HIE and the background is really, really suppressed, yes, that baby's at high risk of seizure. And if the EEG is normal or mildly abnormal in HIE, they're at less risk of seizure. But if it's something else, another etiology, like for example, you're suspecting stroke, the EEG can look quite normal early on, but that doesn't mean they won't seize. And as you can see in this particular pattern, and I suppose what I want to draw your attention to is, even if you don't capture the seizures in a baby with stroke, quite often what we see in quiet sleep, quiet sleep is really, really useful to look at. It's often a period in the neonatal EEG where abnormalities emerge only. It may be normal at other times, but when you look at the quiet sleep phase, and in this particular baby, it was very clear that there were these sharp waves over the side where the injury was, over this left side here. So I should say on my slide, so, if you're not used to looking at, multi-channel EEG, this is just F4 to C4. These are the channels on the right, and these are odd numbers are on the left. So this is frontal to central on the right, frontal or central to occipital on the right, and the same here on the left. So if you just compare these two channels to the second two here, you can see that these two should be exactly the same here, and they're not. So there's clearly different activity on the right and the left. So this is often a clue. Look carefully at the waveforms that you record in quiet sleep as well, if you haven't managed to capture a seizure. So in this particular case, the minute we saw this particular pattern in quiet sleep in this term newborn, who'd had an event that we hadn't seen earlier, we thought, this looks very like this baby could potentially have had a stroke. And yes, that's what the case was. So I just want to tell you a little bit about the ANSWER study, which is a study we did over a number of years to look at how automated seizure detection can help us to detect seizures. And I've had the privilege of working with many centres across Europe, and I've listed them all here. 4 of them are in London, as you can see here. And it's been a fantastic journey to work with this team, because we have managed to recruit almost 500 infants, full-term infants. They've all had multi-channel EEG monitoring from very soon after birth. They were all term infants who were at high risk of seizures, and they had an EEG monitoring commenced. And I'll tell you a little bit more about that study. But I suppose what I want to say is that it has helped us to understand so much more about neonatal seizures, because whatever we do, and what I had previously done to date, it had always been a single-centered study. And I suppose my worry was, it's not that we do things differently in a single center, but I guess you need to make sure that there might not be something in some center that's maybe it's treatment or whatever is happening differently. You need to get multi-center information. And I suppose that's the beauty of the study, of the information I'm going to kind of show you now, is that it's information from lots of centers, 8 centers across Europe. And we've gained a huge insight into how neonatal seizures behave, and their characteristics. And this is just to give you, so from 472 infants actually that we recorded in total from our studies using them across those 8 centres, is we recruited 472 with multi-channel EEG as soon as possible after birth, and 154 infants had seizures in total. Now we've published them as 2 separate studies here that I've listed at the end. One because in the second part of the study we introduced an automated seizure and detection algorithm. But in the first phase, it was purely observational to see, how many seizures are babies having, when do they happen, how severe are they? And what we found in the 154 infants that had seizures is that, as you'd expect, severe HIE was, a lot of 40 of those 154 had a severe HIE. A lot of infants with stroke, but 50 had moderate HIE. And of course, then we had a group with metabolic and genetic disorders, which have different seizure characteristics. And then there were other causes like cerebral malformations and a range of other conditions that, we just categorized into other. But I suppose the thing I want to show you here is that when we look at the seizure burden, by that I mean is the total amount of seizures they had from when recording started to when the recording ended. And we recorded in these infants for up to 4 days or more, basically, but we always made sure that the seizures had stopped for 24 hours. So we wanted to ensure that we captured all of the seizures, and we started very early. So the median amount of seizures that babies were having was 69 minutes. But obviously that varied depending on the etiology. So of course it's really important to know we found a higher seizure burden, as you can see here, nearly 134 minutes in babies with severe HIE. Stroke was quite high actually at 69 minutes. And this, you can see that varies. This is the interquartile range. So, this is just the median value here. Obviously there are ranges. Moderate HIE, 60. Metabolic, genetic disorders, again, a range, but around 36, 37 minutes. The seizure period is the period from when the first seizure started to when the last seizure ended. So how many hours, were those seizures going on for? And again, there was a range of a median of about 16 hours, but again, range from 7 to 40. So babies are seizing over a long period of time. Now, I should say we didn't advocate any particular treatment. We asked every unit to treat those babies as they would, as per their usual neonatal unit protocols. And we didn't provide any EEG expert advice for most of these. They were managing these babies on their own. But I suppose what's important in this big group of babies, so of the total HIE group, out of the 472 that we had, 181 had HIE. And this is looking at the just the moderates and the severe groups actually that we had in the group, obviously not the mild, because these are the groups that had seizures. But in the moderate group, 40% had seizures. And in the severe group, 71 had seizures, 71%. So I think that's useful information to know that if you have a baby with a moderate encephalopathy, 40% will still have seizures. And I know we've talked about all these babies were cooled. So it's not, well, the majority of them were. There was 1 or 2 actually that weren't cooled, but now the majority were cooled in the moderate group and all the severes were cooled. So I think it's important to, we often thought that seizures had gone away because of cooling. And the answer is they haven't gone away. Sometimes they're harder to see. The seizure burden has certainly reduced, but we're still seeing a high percentage of babies with seizures in HIE. What was interesting for me, given that we had this information, was how soon after birth did these seizures start? Because I suppose we're always trying to say, well, we need to detect seizures, we need to detect them early. If we have limited resources and we can't actually get EEG monitoring 24/7, well, when should we try and get it? So we were very interested in seeing when do they start? And overall, we found that, the age in the whole group was around 20 of those babies who seized, was around 22 hours after birth. Now, we did get the EEG, and I'll show you when we got the EEGs on in a while, but it was as soon as possible, and we aimed to get them on, before 6 hours of birth. Some of them were a little bit later. We usually got them on within 12 hours in all babies. So, because we wanted to capture the true seizure burden. But if you look at the groups when the seizure started in the moderate, severe, and other etiologies of particularly HIE, I was interested in at this point, they start early. So if you've got a baby with a moderate HIE, their seizures are going to start. Now, there is a range, of course, but really, you need to be monitoring these babies within 24 hours of birth because you're going to miss most of the seizures if you start after that time period, and I mean with EEG. In the severe cases, again, not very different, but it was a little bit later, but then that's not surprising actually because you have a very severely impacted brain and sometimes the seizures take a bit longer to emerge, but when they do emerge, the seizure burden is much higher. And then in stroke, I'm sure you're not surprised they're a bit later. Now, I suppose the only thing I would say about stroke, it comes with a bit of a warning. We did get the EEG monitoring on a bit later in some of the stroke babies because they didn't reveal themselves as being at risk of seizures until later. You know, the typical case of a baby with a stroke, they go to the postnatal ward, they're fine because there's been no concerns at birth, but then they start to seize later and then they're admitted to the unit. So I'm not sure if this is the exact onset of seizure, but certainly in a lot of them we got the EEG monitoring on very soon after the first presentation of seizures. And in stroke, quite often they present with a clonic seizure. So we got them as early as possible. But in other etiologies, the seizures presented later. So I think that's, HIE, the seizures will present within the first 24 hours, so you need to be monitoring. So what we did in the babies with HIE that had seizures is we just took out those. We knew we definitely had monitoring on within 7 or 8 hours of birth. So really, and what I want to show you here, in all infants, we had the EEG on within 4 hours of birth because we were really interested in when are these seizures happening. And we looked at the moderate and severe, and as you can see, we started very early in both groups. So the age the first seizure started, when we so I suppose we wanted to make sure we were capturing the first seizure. It was a little bit earlier than in the previous slide I showed you because that included all babies, even the ones that started a little bit later. Moderate, 13 hours they're starting, between 8, 9 and sort of 19 hours. And in the severe group, they're starting a little bit later, but not much. However, seizures we know in encephalopathy, they follow a sort of a particular evolution. They start and they reach a peak at a certain point after birth, and then they start to peter out. And what we were looking at was, when do you find the point of the maximum seizure burden? So when does that happen? Because you want to make sure that ideally you want to try and treat these babies before they're really at the phase where they're reaching this high seizure burden, because that could be the point at which most injury may be caused to the already injured brain. So we actually found that the peak of seizures in the moderate group was actually at 15 hours. So when the seizures start, they reach their peak very, very quickly. But in the severes, it took a bit longer to reach the peak of seizure of this, and I'll show you a picture in a minute. But those seizures then, when we looked at how long they went on for from start to finish, they start very quickly in moderates and they peak very fast and then they stop. Now that may be because we treat them very quickly, but we didn't have any particular treatment protocols. We were treating them as per our usual practice. But in the severes, they're harder to control and they take longer. And these are the babies that we have to use, obviously, often multiple drugs to treat them. But just to show you what that looks like then, and here's the picture from an infant with the group of infants with severe HIE. So this is the trajectory of their seizure burden, and this is time, postnatal hours or age. So what you can see is in the severe group, the seizures start, and they kind of reach their peak here around 27 hours. So it takes a while for them to build up to reach that peak. But in the moderate group, this evolves very, very fast. So they start, but then when they start, and there's obviously a range when they start, but they reach the peak of 15 hours. So if you're doing some EEG monitoring, you really want to make sure that you're monitoring these babies at this particular time, because if you're not, you're going to miss them. And you certainly want to try, ideally, and treat these babies before they reach the peak. So what can we use to treat seizures? Well, we can use our clinical assessment, video, and EEG. And I suppose if you haven't seen this, I would recommend you get the new LEA classification of neonatal seizures, because what they have done is, if you want to rely on, if you don't have any EEG at all, and you're in the middle of the night, you can't get monitoring, and if you see some patterns in babies, well, will it help you make a diagnosis? And they've classified these seizures according to motor, non-motor, and different kinds of seizures. And I just want to show you just a few of them. And really, for example, if you have a baby that has automatisms in their maybe mouth movements, like this baby here in the slide who's having very clear sort of lip smacking. This is actually a baby with status epilepticus, a baby with HIE, full-term baby. They're very difficult to recognize. But certainly they're now classified as motor seizures. In the previous classification for neonates, they didn't actually feature. Neonates they weren't classified according to the ILEA classification scheme. They're common in babies with HIE and preterm infants. The clonic kind of seizures that we have, you've all seen these before, but these are the seizures that we often see in babies with stroke. And these are now have their own classification in the neonatal ILEA classification scheme. They're easy to diagnose. And if you see a seizure like this, I mean, I'm sure most of you, you'll probably try and suppress. Can you stop that movement? You can still feel that baby seizing when you try and stop it. These seizures, you'd say, well, I don't need an EEG for that. And I think that's absolutely the case. Tonic seizures can be a little bit more difficult to recognize, but quite often you can see a sustained increase in muscle contraction, like the picture of the baby here. And these are the seizures that we often see, and not your sort of acute symptomatic seizures, but in babies that may have epileptic encephalopathy or a genetic encephalopathy. They're very, very common, and they're quite often associated with more than just the tonic sign. You might see lip smacking with them as well. So important to think about another cause for seizures if you see those. And of course, if you see a baby with sort of motor spasms, these sudden flexion and extension, like this baby here, I mean, you're not going to see this in HIE. These are quite often seen with metabolic and genetic disorders, and they're quite distressing to see actually. But you see the sudden flexion and extension, and they're more sustained than myoclonic seizures. So there's a few things in the kind of the semiology of the seizures that can give you a clue as to what's causing it. And I think this classification scheme that's in this paper here, well, actually it's referred to by Pressler and also by Pellegrin. This classification seems like, what do you do if you only have, you don't have EEG? Well, what they've said is if you don't have EEG and you see a focal clonic or focal tonic seizure, it's probably a seizure. They do rate this as like, you need to treat, it's probably a seizure. If it's another seizure type, it's possible. But if you don't see that seizure and you're relying on somebody else, there's really insufficient evidence to say it's definitely a seizure. Now that's their scheme. And obviously the clonic seizure is the one that they refer to. What is a neonatal seizure? It's on an EEG, it's a sudden repetitive evolving stereotype waveform with a definite beginning, middle, and end. And the minimum seizure duration is 10 seconds. But of course, with the new classification of seizures, they haven't actually put that 10-second duration in. But certainly what you want to see is something that's rhythmic and suspicious because it's different from the background EEG and it spreads. Neonatal seizures don't stay at the same frequency and amplitude when you see them on your AEG or your EEG. They evolve over time. And like you can see in this picture here. But just a word of caution as well with this picture, I just wanted to show you is that sometimes you can see an increase in the baseline of the AEG, particularly when the background pattern is poor. It doesn't always mean it's a seizure because this is the background pattern, which you can see is very, very abnormal in a term newborn. And then you see these increases in the baseline. And all it is the baby's in a very abnormal neurological state. And you're seeing a lot of muscle activity when the baby's quite irritable. And that's all that's increasing the baseline. So really important to look at the raw EEG channels before you say everything is definitely a seizure. But AEG and EEG both have their advantages and disadvantages. AEG has limited, this is just a one channel, but most are two channels now. Conventional EEG, you can put more channels on, but it's challenging to do in a neonatal unit. But certainly AEG monitoring or CFM has evolved hugely in the last number of years. And we have, we went from the one channel that just had the compressed EEG to now we have two channels minimum, and you have your raw EEG traces there as well, which is really important. And in some systems, you even have video as well. Video is really, really useful to review. But with the AEG, you just have to be aware that the signal is quite compressed, and it's very compressed, and the signal is changed a little bit. So you don't have your raw signal. There's a lot of things happen in terms of amplitude compression and downsampling. So you just need to be aware of that. But there are some really good classification patterns for the background EEG. whether you use the voltage classification or the pattern classification. Really good for looking at, is this background pattern normal or abnormal? And I'm sure you all use these when it comes, but you just have to be aware that sometimes the amplitude integrated systems, they're not all equal. If you're using the voltage classification system, sometimes the voltages are different depending on the system that you're using. A good paper here kind of, it's worth having a look at to see what that means for the system that you're using. But when we're trying to detect neonatal seizures, we're trying to detect an evolution. And I just want to show you this picture to show you. This is a typical seizure on a neonatal EEG. It's also, I'm showing you the point in time on the AEG. And with the EEG systems we can create as many amplitude integrated EEG traces as we like. But the EEG evolves. There's 2 waves per second here. And as you can see, it slows down. It changes in shape. The morphology of the waveform changes. And as you can see, it gets slower as the seizure evolves. And that's what you're looking for. If you want a clue to detect it, look at, if it's a constant looking pattern all the time, try and rule out something like an artifact, like respiratory artifact, or are you getting some pulse artifact, or is there head movement because of respiration? Because seizures don't stay constantly the same the whole way through. Whether you're using AEG or EEG, I think AEG depends on your level of expertise. The studies that have been published looking at the sensitivity of the EEG or the AEG varies really depending on what system you're using. Is it 1 channel, 2 channel? Where are you putting the electrodes? We know that if you monitor over the central region, you'll detect more seizures. Inter-rater agreement varies depending on expertise. And of course, the problem you have is that if you don't have EEG, artifacts are difficult to see on the AEG, even with the raw waveforms sometimes. And this is a nice study that just highlights the differences between the EEG and the AEG when you're trying to detect artifacts. I watch my time here, which I'm probably out of. And of course, this is a study just showing that why expert interpretation matters. Because if you start off with neonatal seizures on the amplitude integrated EEG, the level of expertise, you will detect more seizures. Your ability to detect seizures if you're an expert is much higher than if you're inexperienced. But for seizures, we're always trying to, high seizure burden, we'll detect more seizures for sure. If they're lower amplitude, harder to see. And location is important. If the seizures are in an area where you're not monitoring with your amplitude, with AEG, you won't see them. We know that seizures are more common in the central region, so I would always advocate for putting the electrodes there. I won't have time to go through this case, I'm afraid, so I'll skip over that because I want to say a little bit about seizures in preterm infants, just to tell you that they were believed to be very common in the first 3 days in preterm infants, but a study we did not so long ago showed that very few babies, when they were well in the preterm period, only 5% had seizures. There's a possibility, I would just sort of be careful when you're trying to detect seizures using amplitude integrated EEG, because the amplitude integrated, the preterm EEG is very different to the term EEG. And a lot of pattern, like for example, here, there's lots of increases in the baseline that are normal in a preterm EEG that might look like a seizure. So just to be careful, preterm babies do have seizures, but they quite often have them maybe later when there's been some episode of IVH or sepsis. So just to be aware of that yes, preterm babies will have seizures, but if they're well in the first 3 days, they probably aren't having seizures. And again, seizures are more common in the central region and also over temporal areas. They're a little bit shorter, so again, that makes them harder to detect on the amplitude integrated EEG. And this study, just to show you that this is a nice study which just shows that rhythmicity, you can see a lot of rhythmic patterns on the preterm babies have lots of movements that can generate rhythmic patterns on the AEG. So just to be wary of that you may be seeing a lot of artifacts that look like seizures. But this is just to show you the full picture again. Continuous EEG is your gold standard for diagnosing all seizures. But of course, the AEG is really, really good as well. But to be aware that the expertise of the person interpreting the EEG That's why it's listed on this particular algorithm as probable, because it comes with a caveat of your expertise. And that applies as well, of course, to the continuous EEG. I just want to finally end with, okay, so we've got EEG, we've got the EEG monitoring, and you're saying, well, look, I'd love to use continuous EEG all the time, but I don't have that opportunity. Things are happening, not just with our work, with machine learning is learning about neonatal seizures. And I told you about the answer algorithm, but the answer study earlier. We actually evaluated an algorithm that we had developed, which all it did was it told you at the cot site if there was a high probability of seizure. And we randomized babies to EEG monitoring with or without an algorithm. And we had 264 infants in the study. They were equally assigned to EEG detection with or without algorithm support. And you can see that we had 32 and 38 in, depending on which group they were in. And I just want to say that this was a huge effort from the answer team. And what we actually found is that when we had algorithm support, the 65% or 63% of all the seizures were detected versus 46 or 47% when they weren't, which was a much bigger proportion of the seizures were detected. And this was in centres that were really good at using EEG, but still the algorithm had a benefit. But what was surprising for us was that at the weekends, we found that the algorithm works even better, because guess what? At the weekends, the experts that were helping to detect the seizures in the non-intervention arm were not there all the time. So, you know, the algorithm was doing more of the work, and we found that at the weekends that the algorithm actually performed even better. More seizures were detected, and you know, so automated seizure detection does work. And it detects, I suppose, from our perspective, what we found is that the percentage of seizures, if you look at, this is just telling you the seizure burden in an hour, the algorithm every single time detected a higher percentage of the seizures, no matter what the seizure burden was per hour. And I think, you know, to sort of say there's a lot happening in this landscape. Deep learning is now a whole new avenue of artificial intelligence, and it's learning a lot, and we should embrace it as to help. It's never going to replace, but it's certainly going to help with our decision support, and certainly for seizures detection. So in summary, I just want to say that, you know, seizures, they remain difficult to detect, but we've learned a lot about them in terms of when we should monitor them, look at the baby to see what the baby's doing, because it can help us with deciding, you know, what's the etiology, but also how to manage seizures. Conventional EEG, I know, is a challenge still for people, but I strongly believe automated detection will help us with that hugely in the coming years. And EEG, any monitoring is fantastic. And I think you should try and get EEG or EEG, but certainly monitoring is essential for babies at high risk of seizures. So I just want to thank the fantastic infant team that I work with, who have been on a huge journey on neonatal seizures with me, and the answer team across Europe, and the staff in my centre, and the families who participated in all of these studies across Europe, and of course our funding agencies. And thank you for your attention, and I'll happily try and answer any questions if I can. Thank you.
Thank you so much, Geraldine. That was an absolutely fascinating talk. I never tire listening to you. We've got a whole flurry of answers that come in through the talk, which is great to have so much audience contribution. So I'm going to kick off with Steve Jones, who says, do we need to worry about subcortical seizures, which AEG might miss? And I guess I'm thinking as well about the other cortical seizures that AEG might miss, given that AEG really only picks up about 75% of seizures. So you talk about seizures being a neurological emergency. It's made me very anxious now that we might be missing a lot of them.
Do you mean with AEG? Is it that we're missing the seizures with AEG? Yeah, I mean, there's no doubt about the fact that, we will pick up the seizures if they're in this, if you're monitoring we know that 85% of seizures at some point will manifest in the central region. So if you're monitoring in that area, you will pick them up. But of course, it depends on who's interpreting the AEG as well at that time. So there is, expertise matters. And I think the best thing I can say is that if it's HIE, you monitor at the right time. You make sure you're monitoring within the first 24 hours for all your babies with HIE. You make sure you're monitoring bilaterally and that you're monitoring over the central region. But I accept if you're not looking at that EEG all the time, yes, seizures will be missed. Of course they will be. And if it's any consolation, seizures are missed even when you're using multi-channel EEG, because guess what? Nobody's watching that EEG 24/7, which is why I have really pushed to try and get automation involved here, because when an EEG is happening at the cot side, there's no alarm going off like we have for our saturation monitors and bradycardias. We've nothing to give us any clue. Whereas I think if we were able to put more electrodes on and we had an automated tool that was alarming at the cot side, at least somebody would look at the baby.
Thank you. Yeah. So somebody else has written in to say the decision to treat subclinical seizures is very clinician dependent. Do you have a recommended threshold for treating subclinical seizures given the potential impact of treatment, either as a total number of seizures or the length of duration?
Yeah, well, I mean, this is something we've talked about a lot, actually, particularly for the design of clinical trials. And I think the rule of thumb, what we have always got, we rarely don't treat one short seizure of 20 seconds. I mean, you'd always wait to see. So what we look for are 3 seizures more than 10 seconds, or if there's more than 2 minutes of seizures, even when it's subclinical or electrographic only, as we say, if the seizures are 2 minutes more in duration, you have to treat them. These are, like, if you had a seizure lasting for 2 minutes in an older child or an adult, you would always treat it. The fact that you're not seeing it is just because the baby can't tell you there's a seizure going on, or it's in the area of the brain where there's no motor expression, you know. So I do think that we need to, I guess, you know, the rule for clinical trials that we've been using recently anyway is the best evidence that we have. And 3 seizures, you know, if they have 3 seizures, you know, and they last for more than 3 minutes, or if you have 1 seizure for 2 minutes, I think you have to treat those.
Thank you. That's really interesting. So we have a comment here from Nikki Robertson saying, thank you for your excellent update. In your recent answer study, do you see a relation between predominant MRI pattern of injury and seizure burden? And did you have MR spectroscopy and any relation with seizure burden?
Yes, and Nikki, I would absolutely love to answer that question for you. And, you know, and we do have MRI and we have spectroscopy. And at this very moment, Linda de Vries is analysing everything, but she's just finished analysing all our MRIs, and I will have the answer for you very soon. But you're absolutely right. We're really interested to look at the relationship between seizure burden and MRI injury. I don't have the results yet because it has taken us a huge number of scans, and Linda's done an amazing job. But yeah, I agree, it's important.
Thank you. So Natasha Saunders says, our centre's got an old Olympic monitor, which has only got 1 channel. Are they missing many seizures by just monitoring the single channel? And I want to also come in on that, because implementing CFM monitoring as per the new BAPM guidance that all LNUs and schools should use it as well, we're considering whether or not all referring units within Scotland should just be using single channel. What do you consider the risks of that as opposed to
well, you just I mean, I obviously I can't interfere with any recommendations, but I can just tell you what I know from the evidence that we have. I suppose what we're doing at the moment with the answer, so we have, as I say, we have 472 infants that had continuous EEG, and one of the other studies we're now looking at is we're comparing that to both 1 channel and 2 channel EEG. And I will have the direct comparisons for you very soon. But I think you just have to accept that you're not going to be able to see all seizures with 1 channel EEG. There's absolutely no doubt about it. But if you are going to use 1 channel, I would do cross central. Put them over the central region from C3 to C4. That's the best advice I can give, because that's where most seizures will eventually, you will see them at some point there. But you are going to miss seizures, and I can say that, you know, that you won't, but again, if every centre, I mean, I think the guidelines are also recommending a training package as well with that, isn't it? That there's going to be regular training on EEG interpretation. I think that's really welcome and really important as well, because there is a worry about misinterpretation as well, because you could end up with overtreatment if you're misinterpreting some common artifacts that look like seizures as well. So
Yes, I think that's the case where sort of the training is really key, particularly as you talk about how detection improves with experience and expertise.
Oh, without a doubt. And I think there's a number of, like one of the things that we're developing now, which I can, provide details with, is we've developed an EEG, a neonatal EEG training module, an e-learning module that we're going to make available, free of charge actually, because we think it's so important. And it might help to supplement, just recognizing the common patterns. And there's a lot of just real world examples in that module that we're just finishing off the final, and we're hoping, and it's been run through the Epicare consortium, the ERN. So hopefully we'll get that endorsed, and we'll provide that if anybody would like to see some more examples, and that might help with training as well.
Thank you very much. That's great. I wonder if we've got time for a really quick one just before ending. There's so many questions coming in. It's fantastic. Sophie Fitzpatrick says, thanks for the fascinating talk. I just wanted to ask about AEG monitoring in babies with poor cord gases and concerns about possible HIE. In many centres, these babies are monitored and discontinued around 4 hours if this is normal. Do you think we should be monitoring these babies for longer in view of the fact that studies show seizures may start later?
Yeah, I think, we often put the EEG on because, it depends, it's more than just low APGAR scores and cord gases. I guess, you'd obviously have a neurological exam as well to assess if this baby has an encephalopathy. I think there's some studies now that are starting to look at any baby that's had clear evidence of a perinatal asphyxia. And we certainly did a study, and Brian Walsh from our group looked at a group of infants that had perinatal asphyxia, and we had some early EEG monitoring. A lot of those, if they have a normal EEG, and I would say normal EEG, and they have early development of sleep cycles, we don't see seizures in that group, or very, very rarely. And certainly you would see seizures in that group, but there'll always be the exception, I have to say. And I guess it depends. It's got to be a decision, though, based on more than just the EEG. It's got to be, are these babies encephalopathic or not? And one of the other things we look at is obviously more their lactates and base excess and everything else as well. So I think the best I can say is if the AEG is normal, it will certainly be. The AEG is very good for the background, giving you a good sense of is the background normal or abnormal. We always leave the EEG on for try and leave it on for 24 hours, because we know if seizures are going to happen, they're going to happen within those first 24 hours largely. So if you're worried at all, leave it on a little bit longer. Would be my advice.
Okay. Thank you very much, Geraldine. As I said, we could talk all afternoon about this, given the number of questions. There's a lot about HIE, which is great because you can bring those questions to Nikki Robertson's seminar tomorrow. Geraldine, I just want to thank you so much for sharing your expertise with us all today. It's been a really interesting hour of CPD for us all. I'd also like to thank Chiesi Medical for organising the programme and for hosting this event, which is fantastic. And I very much look forward to seeing you tomorrow at 1 o'clock, where we'll have Professor Nikki Robertson, who will be speaking about neonatal encephalopathy and how we can optimise outcomes in 2021 and beyond. Thank you very much, everyone. Have a good day.
Thanks. Bye-bye.
That we have with us today, as well as our neonatal consultants and trainees and neonatal nurses. We also have, and it's great to know that we're all kind of joining as one.
Jeez, it's done it again.